I'm a craniofacial surgeon in Dallas, and I totally misjudged the amount of time it would take me to get from the hospital I work in on a Friday afternoon at 4 o'clock. I don't know what I was thinking. I have a short commute home, and so I'm not used to driving on the highways. But anyhow, I was asked to talk to you today, and I'll try and stay out of the way, about the surgical treatment of abdomens that don't have any muscles with them. And just by way of a quick review, that the stomach normally has 8 muscles, and there are 4 pairs. The rectus abdominis are the big main muscles that are right here. And then there are 3 muscles that come in from the side, on either side, the external oblique, internal oblique, and transversus abdominis. And they make up the 8 muscles of the stomach. And if you have an absence of musculature, that's called triad syndrome, because there's 3 kind of major components to it, or Eagle-Barrett. It's 2 doctors that described it, but I don't see why it should be named after doctors. It probably should be named after patients better. Or Prune belly, which is a very descriptive term, I think. And the surgical repairs fall into kind of 3 basic categories. One is treating obstructions of the urinary system. The other are repositioning the testicles that are high up, and everyone, or all the boys that are born, the testicles start in the abdomen and then they slowly descend just before birth into the scrotum. And there's a number of conditions that prevent those testicles from going down, and kids that are born without absent muscles in their stomach, they have undescended testes. And then the third group of operations are just to sort of tighten up the distended stomach. And there are a couple reasons to consider doing surgery on the stomach. There's a bunch of functions that the stomach needs, that the stomach's helpful for. When you flex the muscles of your stomach, it increases the pressure inside your abdomen. And so that helps you with coughing and evacuating your bowels and emptying your bladder. All those things require to build up pressure inside your stomach. And when your muscles are a little bit, they always have some tone, but when they tighten up, it makes that space smaller, so it increases the pressure and it helps with those functions. And then the next thing it helps, the next group of things is it helps with posture and balance. I put this picture of the spine that I bootlegged off the internet somewhere. And the vertebrae is like a stack of coins. They're different bones sitting on top of each other, and there are ligaments that prevent them from slipping and sliding with each other. And then the muscles in the back and the front work and balance together to keep that sort of straight. And if you're born without muscles in your stomach, you've got all the back muscles, which are really strong, that are pulling one way, but you don't have the good counterforce on the other direction in the stomach area. And there are other muscles that are there that sort of take over. One of your thigh muscles kind of comes up a little bit higher above the pelvis, and there's muscles in between your ribs that can do that. But it impedes your ability to have good posture and balance if you don't have larger muscles there to correspond with the muscles in the back. It's the same thing with exercise performance. The studies have shown that kids that don't have muscles in their stomach, they don't do quite as well with deep breathing and stuff when you're doing a lot of really aerobic exercise. But what happens is the muscles in between the ribs do enlarge and get bigger and compensate. Sometimes some kids will have larger rib cages because those muscles have just gotten bigger, and they take over to help you with the accessory breathing. The third, final point for concerning abdominal surgery is just appearance, because it looks better to have a stomach that's flatter than the stomach that's not as flat. So those are kind of the 3 reasons to consider treating the abdomen. Among the historical treatments, the first thing that was really considered was an abdominal corset. And I took this picture from Eagle and Barrett's article, the original publication they did, where they described a bunch of children that had absent abdominal musculature or prune belly. And so early on, doctors would consider a corset, just some kind of wrap for the stomach to keep it flatter. And then in 1981, 3 doctors reported, at least the first report of surgery I could find for prune belly, a horizontal incision for a resection. And the great thing about making an incision down there is you don't have a vertical scar. So if you wear shorts or pants, a lot of times you can hide that incision. So that's a really nice incision. In fact,
my colleagues that do cosmetic surgery, when you do tummy tucks, you make a incision like that to cut around the belly button, pull it all down, and trim it off, and you hide the scar in there. And it's interesting, in this article on treating prune belly, they drew a picture with muscles in it. And then in the mid-'80s, a urologist and a plastic surgeon, one of them, Mel Essifoy, is a guy now, I think he's still maybe in practice or getting close to the end of his practice. They described this pant over vest repair, which I think is actually a pretty good idea. And you lift the skin up off the fascia of the muscle, and then you cut the fascia in the midline, and you bring one side all the way over and the other side over, so you get kind of double layer. So it's a doubling the strength, so it's less likely to distend out as a treatment. I think it's a good idea, actually. And then subsequent to that, a group in France published doing lateral excisions, and the benefit of this is if you had a urachus or something that looked like a belly button, you could preserve it with the lateral extensions and close up. It became known as the Montfort correction, and that was really the correction that was, I guess, most popular during my training and when I was starting early in my career. And then subsequent to that, some doctors in Valhalla, New York, and I think they were in Chicago too, described a procedure where you didn't even get into the abdominal. You don't even cut the fascia open. You just kind of raise it up as two mountains and you fold them together to get even more layers. You get 3 layers of that, but you still have the lateral layers here that can enlarge. So those are some of the historical treatment. And my approach started in 1995. I've been in practice for 5 years, and a patient was sent to me that had absent abdominal musculature that was ventilator dependent because he just wasn't coughing well enough, and so he'd get lots of colds, and it was kind of hurting his lungs a little bit. And so I looked at all the kind of static repairs that were there that tightened the fascia, and I just didn't like the fact that any of them wouldn't bring function to the abdomen. And looking and searching for what I could do, I came across a paper written by Dr. Gurr, who in the mid-'80s, he published in our journal in Plastic and Reconstructive Surgery an article on rebuilding abdominal defects, people that were missing sections of the stomach where he would use different legs. And it had been described by others using the rectus femoris, and he just had a big series of this. And after he sent it in for publication, he'd done his first patient with prune belly, and he said, you know, subsequent to my sending this article in, I have done a patient with absent abdominal musculature, and I thought it worked well. And I looked for the report of that, and I saw no follow-up or anything like that. But I liked the idea that of using a muscle going to the stomach to bring kind of function where there wasn't function. So I did my first patient, and these are 2-year follow-up pictures. And right after surgery, he got off the ventilator. So I was really encouraged that the muscles were working. He had to go back to the operating room a couple of years later and for another procedure. And so I went into the operating room and used a muscle stimulator to see if the muscles were functioning, and they were definitely functioning. So I got kind of enthusiastic about doing this, and it was just last year I finally got in touch with Dr. Gurr. Actually, Frank actually helped us to get together, and so I talked to him about his experience and thanked him for his idea, and he sent me this article that he'd written in 2000, which shows him taking the thigh muscle and bringing it up to the stomach. So my personal approach, I've had 9 patients. One I've not yet treated. I think he was too young, and I've done 6 muscle transpositions, and then there are 2 patients where I intended to do it, but when I opened the abdomen, I saw that there was some muscle there. And so I made the decision, well, if there's some muscle there that might have some inherent tone, I was going to hold off on doing a bigger operation. I like treating I just treat pretty much kids in my practice. And I like treating like they're my own kids, and I like the idea of doing the smallest operation that I can do.